Okay.
Well, good afternoon. It's a huge pleasure to be here today, especially because it's the first time dentistry is being discussed in a Preventing Overdiagnosis conference. So it's also a huge responsibility. Are there any dentists here? One, two, oh my God. I was actually relieved because I was sure there would be no dentists here. Now I'm a little bit worried. Okay. John, earlier this morning, you were complaining about the accents of English native speakers. So now you'll be punished because you have to listen to the Brazilian accent. So I'm so sorry, but hopefully you understand everything. This presentation is based on a paper that's being written in collaboration with Paula Nadanovsky, Stephen Woloshin, and David Noonan. And I'll begin by presenting some compelling data that show the prevalence and economic burden of oral diseases. So this figure shows the 20 most prevalent diseases in 1990, 2007, and 2017 among more than 300 diseases and conditions in 195 countries. Oral disorders and headache disorders had the highest age standardized prevalence across the 3 periods analyzed. These are the estimates for women, but those for men also show oral and headache disorders as the most prevalent ones. And combining data from women and men, in 2017, there were more than 3 billion cases for each disorder. This table shows the healthcare estimated spending in 2016 in the United States for the 100 most expensive health conditions. And restorative dental care and preventive dental care combined with orthodontics were the most expensive healthcare expenditures, totaling $137 billion. So restorative dental care and preventive dental care are represented in this table by the categories oral disorders and well dental. So this amount of spending exceeded the spending on major health conditions such as diabetes, ischemic heart disease, hypertension, breast cancer, dementias. When it came to out-of-pocket payments, again, oral disorders and well dental, that is, restorative dental care and preventive dental care combined with orthodontics were the costliest categories. Also, between 1997 and 2016, medical marketing saw a substantial increase in the United States, and dental centers accounted for the second highest spending on direct-to-consumer advertising of health services. So these findings indicate that oral diseases are a major public health concern. They cause dental pain, tooth loss, infections, and affect people all over the world, even those living in high-income countries. So dismissing oral diseases as minor in comparison to other health conditions that are managed by healthcare services is a misconception. These findings also show that society should be concerned not only about how diseases and treatment needs are defined in medicine, but also in dentistry. So in this presentation, I will demonstrate that in addition to the high prevalence of oral diseases, a substantial portion of dental treatments and expenses are a result of overdiagnosis. But how exactly does overdiagnosis occur in dentistry? As you all know, and according to John's second most cited paper, overdiagnosis means identifying diseases and conditions that were never going to cause any harm, turning people into patients unnecessarily. And in dentistry, it also often arises from redefinitions of diseases or lowering the threshold for diseases or risk factors. Dentistry is a very broad area with different specialties, and overdiagnosis is pervasive among these different specialties, including periodontology, orthodontics. But today, I'll focus on dental caries. So basically, dental caries is caused by sugar in our diet. It's a result of sugar metabolism by oral bacteria, and the primary byproduct of this metabolic process is lactic acid. So as acids build up, the pH drops, and this can lead to the demineralization of dental enamel. To a certain extent, acids can be neutralized by the buffering action of saliva. But when the challenge is too substantial, early signs of caries become visible as white spots, as you can see in this picture. And these white spots can progress into cavities. Before the 1970s, dental caries or tooth decay was rampant and led to a never-ending cycle of cavities, toothache, infections, and tooth loss. This became known as the repeat restoration cycle or spiral of damage, and was especially prevalent among those born in the 1920s and 1930s. But then, in the 1970s, there was an unexpected and extraordinary decline in caries, and it was mainly attributed to the addition of fluoride to the toothpastes. But another reason for the decline in caries was the change in the diagnosis criteria and treatment approach. So there was a shift from if in doubt, feel it, which means that sound teeth, like this one in this picture, with stained pits and fissures, would become filled, like these other teeth in these pictures. But then, this approach changed, so from if in doubt, feel it, to if in doubt, wait and see. So these perfectly sound teeth with stained pits and fissures were no longer filled. Until the 1970s, it was common practice for dentists to fill teeth like these teeth that I'm showing you in these pictures. And in part because they believed these teeth would become decayed anyway. So you may think that this change in the treatment approach was positive, and in fact it was, and I'll come back to it in a moment. But this shift from a time of high levels of dental diseases and treatment needs for one of a significantly lower disease rates and treatment needs had a huge impact on dentists' workload. And eventually, it led to overdiagnosis and overtreatment. So basically, dentists changed the definitions of dental diseases and treatment needs, and these changes affected several common procedures in dentistry, including caries diagnosis, restorative treatment, dental checkups, periodontal diseases diagnosis, scaling and root planing, malocclusion, orthodontic treatment needs. But I'll show you a few examples of how overdiagnosis and overtreatment occur regarding dental caries. So this is the International Caries Detection Assessment System, known as ICDAS, and it's been widely used in the last 20 years. In this caries diagnosis threshold, levels 5 and 6, we can see an obvious cavity that requires filling. But as I've mentioned, in the past, dentists diagnosed caries at earlier stages in order to fill them, which means that earlier lesions at levels 3 and 4 were not only filled, but dentists also extended the fillings beyond the cavities, destroying sound tooth tissue, because they believed that large amounts of sound tooth tissue should be preventively removed in order to avoid future decay in the adjacent sites. But then in the 1980s and 1990s, there was this positive shift in the treatment approach. So although dentists still feel small lesions like this one, they've embraced minimally invasive restorative techniques that preserve sound tooth tissue. And this has been greatly beneficial for oral health. But nowadays, the focus is to intervene as early as possible, at earlier stages, at levels 1 and 2, where no cavities exist, only white spots, and at these levels, dentists employ non-operative procedures, such as resin infiltration. I'll show you what is a resin infiltration in a few moments, or fluoride application. So dentists have moved from operative to non-operative management of dental caries. They now diagnose and manage caries at very early, non-cavitated stages. But there are two main issues with this current practice. First, most lesions at levels 1 and 2 do not progress into cavities. Second, there's no evidence that preventive interventions applied at these early stages of caries, when compared to no intervention at all, are beneficial for oral health. They reduce the incidence of dentin cavities, for instance. So this, the adoption of new caries diagnosis thresholds and early treatment approaches are examples of overdiagnosis and overtreatment in dentistry, because they turn lots of people without cavities into perpetual patients without any evidence that these measures reduce the incidence of cavities, toothache, infections, or tooth loss. And in order to increase the sensitivity of the visual examination, many dental associations, including the American and the European Academies of Pediatric Dentistry, recommend the use of dental X-rays even for preschool children with no signs of caries. But this standard practice of combining visual examination and dental X-rays to detect caries at earlier stages has caused more harms than benefits. And it has been shown that it has led to the detection of false positive cavities and overdiagnosis. So when patients are diagnosed with earlier caries stages, they enter into a repeat prevention cycle. So remember the repeat restoration cycle? Well, it continues to exist, though to a lesser extent, and is now accompanied by a repeat prevention cycle, which includes a package of unnecessary or ineffective treatments, such as 6 monthly dental checkups, dietary advice, oral hygiene instruction, professional cleaning, scaling and root planing, periodic dental X-rays, and etc. So these pictures show very young children during their dental appointments, which may include, among other things, fluoride application and dental X-rays. These pictures also show that these procedures demand professional time and lots of dental consumables and disposables. So when in these dental checkups, when the dental X-rays detect a very small radiolucency, then an elastic band is placed between the teeth in order to move them. And if a white spot is detected, then a series of treatments become available. So then patients may undergo very strict fluoride application regimens, or they may choose from other more recently developed techniques, such as the one I'm going to show you now. So this sequence of pictures show the application of a white spot infiltrant. And in this procedure, dentists use a rubber dam, they place a wedge to move the tooth and infiltrate the white spot lesion with a very fluid resin in order to stop caries progression. Naturally, now patients have to be closely monitored, periodic x-rays have to be taken in order to assess the progression of the lesion. Unfortunately, many of these procedures may be ineffective or unnecessary, but they waste valuable time and resources within the dental services. Let's now take a look at what happens when people change dentists. 1 year after a national dental survey in Scotland, almost twice as many tooth surfaces were filled in comparison to the estimates that had been predicted by the survey. And when people changed dentists, the results were even worse. So those who, over a 5-year period, had changed dentists at least once, received 14 fillings, and those who stayed with the same dentist received 7 fillings. The issue of over-treatment was so pervasive that it led to the publication of the report of the Committee of Inquiry into Unnecessary Dental Treatment. But despite these efforts, evidence of unnecessary restorative treatment continued to emerge. A study in Rio de Janeiro found that people without treatment needs had 2 teeth treated after a 6-month follow-up period. And this number increased to 3.6 if the patients had changed dentists. Another further problem with the current practice is the lack of evidence that preventive visits to the dentists are beneficial for oral health. The 6 monthly dental checkup is probably one of the most common recommendations in dental public health. It's included in dental programs worldwide, yet it's probably one of the least evidence-based recommendations in dental public health. And it's been questioned for more than 40 years, as you can see in this paper published by Aubrey Shihon in The Lancet in 1977. By the way, Aubrey Shihon was a brilliant dental public health researcher. He was from South Africa, but he had been based in London. He was a professor at University College London, and when he published this paper, he received very harsh criticism and personal attacks and threats. Basically, people were trying to, including attacks from the British Dental Association, basically people were trying to send him back to South Africa. The Cochrane review on the subject of recall intervals was updated in 2020 after the publication of the interval trial. The interval trial was a UK-wide, multi-center, pragmatic randomized control trial in primary care setting. And this review included 2 studies. Neither of them have demonstrated that shorter intervals between dental checkups, including the 6-monthly dental interval, are better for oral health when compared to longer intervals, such as 12 or 24 months. Actually, the authors of the review concluded that longer intervals may not affect tooth decay, gum disease, or oral health-related quality of life. So what's the way forward? Well, overdiagnosis and overtreatment are often a result of dentists' lack of knowledge regarding the natural history of dental diseases and the effectiveness of the available treatments. Unfortunately, the effectiveness of many dental treatments has rarely been assessed using meaningful outcomes, such as toothache and tooth loss. So to address these issues, of course, diagnosis, exams, and treatments should only be recommended when the likelihood of benefit outweighs the likelihood of harms. And also, many health professionals, including physicians and dentists, misinterpret the statistics regarding the accuracy of diagnostic tests and the effectiveness of interventions. So we should improve the way we communicate research findings. And also, as financial incentives may be an important driver in overdiagnosis and overtreatment in dentistry, we should assess different methods of paying dentists and compare and assess their effect on oral health, overdiagnosis, and overtreatment and undertreatment. Finally, just the last slide. The issue of inadequate access to dental care consistently raises concerns. And in fact, of course, the lack of access to dentists is a serious issue. For instance, in the UK, extensive discussions have been ongoing regarding the NHS dentistry crisis. And news reports frequently feature patients unable to access dental care, with some resorting to extreme measures, like pulling out their own teeth at home. So we should address how overdiagnosis and overtreatment in dentistry are leading to underdiagnosis and undertreatment, creating barriers for individuals in dire need of dental care. So the time and resources that are currently dedicated at unnecessary or ineffective treatment could be better utilized by providing dental appointments and dental treatment to those who really need them. But it must be acknowledged that access to dentists will not, even good dentistry without overdiagnosis, will not solve the problem of dental caries, because caries is caused by the mainstream drivers of high sugar consumption. So that's it. Thank you.